Welcome back to the Movement PhD. I'm Dustin Hardwick, a physical therapist with a PhD in movement science. Today is our third episode related to the physiology of tissue. I will link the videos to viscoelastic properties and properties of muscle in the description. Today's episode will be an introduction to the properties and healing of ligaments, tendons, cartilage, and bone. As usual, you can find slides in sync with the video on YouTube and Spotify. You can also listen on all of the major audio podcast providers. If you prefer to read, you can find the slides and notes with a summary on my Substack. We will get started today with a review of the load deformation curve. This graphs the relationship between the load, or the force applied to a tissue, and the deformation, or the change in length of that tissue, on a graph. This graph has a few important regions to review. From the intercept to A, we have our toe region. In the toe region, the slack of that tissue is taken up. From A to B, we have the elastic region, or the linear region. In the linear region, the deformation of the material is transient. So if I take the load off of that tendon, it's going to return to its original length. So most functional activities occur in the toe and elastic regions. When we get to the plastic region now, that deformation is going to be relatively permanent because there's micro trauma or micro damage to that tissue. And that's from B to C. When we get to C, we reach that ultimate failure point. So now the tissue is going to pop, or it's going to rupture. So we're going to have a complete resection of that tissue. So the load of that tissue is going to fall to zero beyond that ultimate failure point. A stress strain curve is the same thing as this load deformation curve, but now we divide it out by the size of the tissue. So this allows us to compare tissues of different sizes to see how their viscoelastic properties compare. Now let us review those viscoelastic properties. And viscoelasticity just means that tissue have some properties that are elastic like a rubber band and other properties that are more fluid-like. So they exhibit that viscosity. There are four main viscoelastic properties. Creep. If I impart a constant force, so we keep the force constant, over time, that length of that tissue will gradually increase. And we can take advantage of this property during a low load stretch. The second property is stress relaxation. So now we lengthen the tissue to a specific length, and now the force needed to maintain that specific length is going to decrease over time. And you can feel this during manual stretching. When you stretch a tissue to a specific length, the amount of force needed to hold it there, that's going to go down over time. Hysteresis, this just means that when you lengthen and relax a tissue, the load deformation curve is not going to follow that same path. And the difference between that is going to be the heat released, or the energy that is lost during that loading and unloading. So this is why a dynamic stretch heats up tissue, because some of that energy is lost as heat when you lengthen a tissue and release it. So that heat builds up in the tissue itself. Strain rate sensitivity, our final property. Tissue behaves differently if you load it rapidly versus slowly. When you rapidly load tissue, it is stiffer. When you load it more slowly, it is less stiff. And that is functionally important because when I'm moving slowly, I don't want to impart as much stress on my tissue. So it's good that that stiffness is going to be decreased when I'm moving slowly. But when I need to impart forces quickly, so I need to jump, I need to sprint, those tissues are stiffer, which allows me to impart those forces into the ground more rapidly and allow me to be more efficient with the running or that jumping. Before we talk about specific tissues, their properties, and healing, let us talk about the three phases that tissue in general goes through during the healing process. We're going to start with an inflammatory phase. We're going to move from that into a proliferation or reparative phase. And finally, we're going to end up in a remodeling phase. I really love this graph because it presents those three phases as a continuum, because there are different parts of the tissue that can be in different phases depending on how close they are to the injury site, depending on their vascularity or the type of tissue. So when it's presented as three distinct phases, that's not exactly correct. So I like how this graph shows that there is overlap between the phases. Not only is there overlap between these three phases, but during the healing process, you can fall back to previous phases if you do something to re-injure that tissue. So say you had an injury to a tendon and you return to running or your sport too early, you might fall back from mostly being in the proliferation phase to now you're back into an inflammatory process. So I think this graph is nice that it shows it's a continuum, and it also infers that you can move between these phases depending on the activity level or re-injury to that tissue itself. The first phase of healing is the inflammatory phase, which also includes the bleeding phase. Sometimes these are broken up, other times they're collapsed. I'm going to talk about them together. This is roughly the first week after injury, and I say roughly because the time frames can change depending on the type of tissue and the extent of the injury. So it's going to start immediately after injury. Immediately, we're going to have some vasoconstriction and clot formation with the goal here to prevent bleeding. Then we're going to transition to vasodilation and an increased permeability of the tissue that allows all of those proteins and other cells to come into the area to do their work. The neutrophils, the macrophages, those are going to come in, clean up the dead tissue, the debris that doesn't belong there. And they're also going to start the process by which growth factors and other things will come to that area and start the healing process. So clinically, this is going to be redness, heat, swelling, a lot of pain in this phase, and potential loss of function depending on the severity of injury. The second phase is the proliferation phase or the repair phase. This is roughly the second week through a few months, depending on the type of tissue. The goal of this proliferation phase is to rebuild and cover or bridge that injury. So depending on the tissue, there's going to be deposition of immature collagen or other tissues. Basically, it's the formation of a scar. To support this formation of the scar and the deposition of this new connective tissue, you're going to see a whole lot of capillaries being brought into that area because this process requires a lot of blood supply, so that recapillarization of that area is going to be extensive. The final phase of healing is the remodeling or maturation phase. That starts the first couple of months after injury. It can last for years depending on the type of tissue. The goal of this remodeling phase is to take that immature, disorganized collagen that was deposited in that proliferation phase and replace it gradually over time with more mature tissue that follows the stress lines of the tissue itself. So it's taking that disorganized tissue and making it more organized and more mature. Vascularity is going to decrease over time because the metabolic needs of this tissue are going to decrease. Even though we get full healing, that tissue itself may only be about 80% of the original tensile strength of the tissue. That's the case for a lot of tissue because some of that scar remains even after this remodeling phase. Let's move into this tissue-specific part of this discussion. Let's start with a bone. Let's start with the anatomy of a bone as a review. So the diaphysis is the long shaft of the bone itself. The epiphysis is the ends of the bone, with that epiphyseal plate being that growth plate that allows those bones to grow during childhood. And then the metaphysis is the area between that epiphysis, that end, and that diaphysis, that shaft of that long bone. The periosteum is the covering around the bone itself. This area has a lot of nerve endings, so it's pain sensitive. We have the thin layer lining the cavity, that's the endosteum. And then finally, we have that medullary cavity, which is the hollow chamber in the bone itself. This is where red marrow produces blood cells and yellow marrow being that adipose tissue within that bone itself. There are two types of mature bone. We have that cortical bone on the outside that is dense and hard. We have that cancellous or trabecular spongy bone on the inside. Let's quickly review the blood supply and innervation of a bone. Our main blood supply comes from that nutrient artery. So it enters the shaft through the nutrient foramen. passes through the medullary cavity and divides into both ascending and descending branches, so branches that go up and go down, to supply the bone marrow and the inner 2/3 of that cortex. The periosteal arteries, these are numerous small arteries that penetrate the outer cortex and supply the roughly outer 1/3 of that compact bone. The epiphyseal arteries and metaphyseal arteries, these vessels enter near the ends of the long bones to supply that metaphysis and that epiphysis with blood supply. Innervation. Bones are richly innervated with both sensory fibers, so A delta, fast pain, and C fibers, that's slow pain, as well as autonomic nerve fibers. They enter alongside those nerves and innervate that bone through those means. I have alluded to this earlier, but bone grows and remodels according to the stresses that are imparted upon it, which is Wolff's Law. You may have heard of that before, which states that bone grows and remodels in response to the forces that are placed upon that tissue. However, one thing to realize is that the forces on a bone are not always the same or consistent throughout that bone. I'm going to use the femur as an example, but there are a lot of other bones that exhibit this properties. Because we have a neck on that femur, which attaches the shaft to the head that offsets the shaft from the joint itself, because of that, when we put our body weight through the femoral head on the medial aspect, you're going to get compression. And that is because that line of gravity is medial to the shaft of that bone, so it's going to cause compression to the medial aspect of the shaft of that femur. And you're going to get a line of tension on the lateral aspect of that femur because it's bowing towards that side, so that tension is going to be on the outside. So now, according to Wolff's Law, the calcium that's being deposited in the femur are going to resist compression on the medial aspect of the shaft and resist tension on the lateral aspect of that shaft of that femur. We see numerous changes to bone as we age. We see a change in the mechanical properties of the bone with aging. So we see a decrease in stiffness, decrease in fracture toughness, and decrease in ultimate strength. All of these measures decrease approximately 5% per decade, starting at about 30 years of age. We also see a decrease in the amount of bone. And this is particularly prevalent in women. This can lead to osteopenia and eventually osteoporosis. And that can be modified by things like activity level. So weight-bearing activities such as walking, running, and weight training types of activities are protective of that bone mass or the amount of bone. Also, hormonal changes and your diet can have some impacts on that as well. Speaking of bone fractures, there are many ways to classify the fracture of a bone. And that can be related to the position of the bone ends after the fracture, the completeness of the break, the orientation of the bone to the long axes following the fracture, or whether or not the bone's ends penetrate the skin itself. So a complex or comminuted fracture just means that there are more than 3 pieces of that bone after the fracture. A wedge fracture just means you're going to break off a wedge-shaped piece of that bone. We can have a displaced fracture, just meaning the fracture ends are displaced from one another. And we can have a compound fracture in which the fragment end pierces the skin. A few other things worth noting here. A green stick fracture, this only happens in children. So when you get torsion on the bone, torsion or a bending force on the bone itself, instead of breaking in 2, it's going to break on the outside of that fracture, but the medial side of that fracture is going to stay intact. So think of trying to break a tree limb from a tree that's alive. It stays intact on the side you're bending towards, and it breaks on the convex side of that bend that you're putting on that stick. A couple other things, an avulsion fracture just means that the tendon pulls a piece of bone off of it. So it displaces the part of the bone that that tendon was attached to. In order for bone to heal, there are a few requirements that must be met. You must have viable fragments. It just means that the blood supply is relatively intact. There is direct or intimate contact between the fracture fragments. So it just means that one fragment can't be displaced from the other. So that's why we do a reduction, is to bring those fragments together. And we need some kind of mechanical rest. So that can be an external immobilization, such as a cast, or an internal fixation, like a plate and some screws. And there needs to be an absence of infection, because that's going to take away the resources needed for that bone to heal. Things that we can do to promote recovery: stop smoking, because that has a deleterious effect on bone healing. Don't drink too much alcohol. Again, that's going to impede the healing of that bone. Balanced diet with sufficient calcium, because the calcium needs are going to be increased during this period. And adhere to all of the activity restrictions. So don't weight bear when you're not supposed to. Maintain the strength and range of motion of the other joints so that we don't have impacts on function once that cast is removed. And maintain fitness level with modified activity so we don't have negative effects on our cardiac system. In general, bone follows the same 3 phases of healing as other tissues, but there are a few things that make bone healing unique. The first is that the reparative phase is broken up into 2 subphases. We have a soft callus subphase, where the 2 fracture ends are joined by a matrix of collagen, or basically a cast of where that bone will be later. In the hard callus phase, that soft callus is replaced with mineralized bone. So this is our clinical healing at this hard callus phase. So that's when you can take that cast off, because once you have the mineralization of that callus, that fracture is considered stable. However, in the remodeling phase, that callus is going to basically then be resorbed and be replaced with mature bone that is almost indistinguishable from the pre-break bone itself. Therefore, bone is one of the few tissues that actually heals by true regeneration rather than leaving a permanent fibrous scar. So with a successful fracture heal, the callus and temporary bone are completely remodeled back into the mature architecture of that bone prior to the break at near normal strength and near normal mechanical properties. The final unique thing about bone healing is you can get a primary direct healing without a callus formation. So basically skipping over the entire proliferation phase with precise reduction and very rigid fixation. This only really occurs when you have an internal fixation where the surgeon goes in and makes sure that reduction is precise, so those bone fibers are aligned as close to pre-break as possible, and a very rigid internal fixation. The next tissue we're going to talk about is cartilage. There are 3 main types of cartilage. We have our hyaline or articular cartilage. This is a cartilage that lines synovial joints. We have our elastic or our yellow cartilage. That's a highly bendable, the cartilage in your outer ear is an example of that. And we have our fibrocartilage. This is a white type of cartilage that's very dense. Rows of thick collagen in a matrix, resists compression and tension. We've talked about that in previous episodes when we talked about the intervertebral disc in your lumbar spine, and we talked about those meniscus in our knees. We're going to talk mostly about that articular or that hyaline cartilage for today. There are a couple important properties about articular cartilage that we must keep in mind. There is no direct neural input, so pain is going to be secondary to the subchondral bone changes. So once we wear through that cartilage, the underlying bone is where most of that pain signals are going to be coming from. The other thing is there is no blood supply directly to the cartilage itself. Thus, it does not heal itself very well. It receives some circulation from the underlying bone, but most of it's going to be from diffusion from that synovial fluid. There is no cell turnover, so you have a finite amount of articular cartilage. So this is an important one. The articular cartilage that you have right now is the most amount of articular cartilage you will ever have. That's why osteoarthritis is considered a progressive disease, because it's not going to heal itself because you have a finite amount of that cartilage. So take care of that cartilage that you have. Now let's talk about the zones of that articular cartilage. And there are 4 major zones, and they differ in their function and they differ in the orientation of the structures that make up these zones. In zone 1, that's our superficial zone. That's the outermost layer of that articular cartilage. The goal here is to reduce friction between the two joint surfaces. Therefore, the collagen is going to be oriented horizontally. There's going to be a low amount of proteoglycans because their goal is for shock absorption, not for friction reduction. And the chondrocytes are going to match that of the collagen, so they're going to be flat. So again, this is a thin zone of mostly horizontal collagen with the goal of reducing that friction between the two sides of that joint. The next zone, or zone 2, is our middle zone. The goal of this middle zone is shock absorption. And the fiber arrangement and the proteoglycan content is going to reflect that. So the collagen fibers are going to be randomly arranged, so they're going to form a lattice work. So they're going to be springy to resist that shock. There's going to be a high amount of proteoglycans, so those proteoglycans are all negatively charged and they're taking up a bunch of space. So since they are all negatively charged, they're going to repel one another. So again, that makes that middle zone like springy, so it's going to be there for shock absorption. The chondrocytes, they're fat and they're round, they're taking up space. So all of these things are going to reduce shock through two different mechanisms. The first is just the mechanical parts. So that random orientation of those collagen fibers, they're going to be springy, like a memory foam mattress. Those proteoglycans, they're going to be repelling one another. So again, that's going to make it springy, like a shock absorption. Finally is the fluid part of that shock absorption. So within this whole matrix, there is fluid. When we compress this middle zone, that fluid moves throughout it. Because there's a bunch of collagen that's randomly arranged, we have a bunch of proteoglycans that are taking up space, we have chondrocytes that are fat and round, it's going to make that fluid go slowly through that matrix. So they're acting like a piston. So this middle zone is going to be reducing shock through the mechanical, so the collagen plus the charged proteoglycans, and the fluid like a piston from that fluid going slowly through that lattice work of collagen and proteoglycans. Our next zone is zone 3, or the deep zone. Our goal here is for structure. So now our collagen fibers are arranged vertically, and some of them cross through the tide mark, which is the demarcation between zone 3 and zone 4, which is the calcified cartilage. So this is helping to keep that cartilage on the subchondral bone itself. Again, we still have a high amount of proteoglycan because there's still some shock absorption in this zone 3. In our chondrocytes, they're going to match the vertical arrangement of that collagen, so they're going to be fat and in columns. So again, zone 3 is there for structure with a little bit of shock absorption. Finally, zone 4, that's that calcified cartilage. That's what's keeping that cartilage stuck to the bone itself, so keeping it in place. I previously mentioned that articular cartilage is finite and there's no cell turnover. Therefore, the amount of cartilage that you have now is the greatest that it will ever be. Therefore, we want to find a balance between sufficient movement but not overloading that cartilage. So motion is lotion for your joints, and that is true. So you need some healthy loading, some healthy movement of that articular cartilage. That's going to help to replenish that cartilage with nutrients through that synovial diffusion. So what we don't want is to have repetitive movements with poor mechanics. So we don't want to repetitively load just the medial compartment of the knee, for example. So what do we do about that? Prevent those poor alignments so that we distribute those loads over a larger area. Therefore, that motion continues to be lotion instead of starting to break down that cartilage. Because what happens if we repetitively load that cartilage under poor mechanics? Well, we get breakdown of that collagen matrix. So those proteoglycans are attached to that collagen. So as we break down the collagen, we lose those proteoglycans as well. Therefore, we have lost the springiness of that cartilage. We've also lost the negative charge within those proteoglycans. So now the cartilage is less able to resist compression. So it continues to break down at a more rapid rate. That's why osteoarthritis is a progressive disorder, because once it starts to rapidly increase because we're breaking down the mechanical properties of that cartilage itself, which therefore increases the stress on the remaining cartilage and it breaks it down faster. So again, we're looking at good movement with good alignment that distributes those stresses over a larger area, avoiding repetitive malaligned movement types. Next up, we're going to talk about ligaments and tendons. I'm going to talk about these together because they share a lot of mechanical properties and organization. So they're organized in a very similar way, where you go from the largest tissue down to a fascicle, down to a fiber itself, down to a subfibril, and finally a monofilament itself. So the hierarchical organization of ligaments and tendons are very similar. Now let's talk about some differences between tendons and ligaments. Tendons, they connect muscle to bone. So their goal is to take the forces that you impart in a muscle and move the segment that that tendon attaches to. So therefore, tendons are inelastic relatively and tough. So they're inelastic because they want to be able to impart the forces that you're generating in the muscle to that segment it's moving. The fibers are present as a compact parallel bundle because they're parallel because the forces imparted on them are always in the same direction. So they develop this parallel architecture. The fibroblasts, they lie in continuous rows. This allows them to talk to one another more readily, to allow them to change their properties based on the forces that you are imparting upon them with your muscles. Ligaments, on the other hand, they connect one bone to another bone, are usually found across joints. Therefore, they provide stability, both mechanical and proprioceptive stability to the joint itself. Therefore, ligaments have a little bit more elasticity. It allows them to dissipate some of those forces at the joint itself. The fibers are not arranged in the same parallel bundle as the tendon because joints have forces in many different directions, so having them not be parallel allows them to resist forces in other planes of movement. The fibroblasts are scattered, so they're not going to readily talk to one another as much as in tendons. Now let us compare the stress-strain curve of a tendon versus a ligament. There's a lot of similarities here. They both exhibit the toe region where there's a little bit of waviness of those collagen fibers. They both have an elastic and a plastic phases leading up to that ultimate failure point. So a few differences here. Ligaments, they're more elastic and less stiff, so you see less steepening of that elastic or that linear zone. That's because they allow some give to protect that joint at relatively low loads of stress, but still are able to provide that stability as that stress or that strain increases. You get about 6% change in length for ligaments over that linear period. For tendons, it's going to be less elastic and stiffer. Therefore, the slope of that elastic region of that stress strain curve is much steeper than that of a ligament. And that's to allow the muscle force to be imparted on the bone that it attaches to. So we're talking only about a 2% strain within that elastic or linear part of that stress strain curve. The final thing that differentiates these two is based on that parallel orientation of your tendon versus less parallel orientation of the ligament. Because of that parallel structure, the force ramp up of a tendon is much smoother than a ligament, so it allows you to grade the force of your muscle contraction to the bone that it's moving upon. This slide is just to remind you that ligaments stabilize that joint through two different mechanisms. The first is your mechanical stability. So this is the ability to mechanically guide joint movement. So thinking about the ligaments of the knee, they passively prevent varus or valgus stresses. They passively prevent rotational forces on the knee joint itself. But that's not all they're doing. They're also there for proprioception. So they're giving you an idea of where that joint is in space, and it can actually then act through some of those reflex arcs to protect that joint when you get to the extremes of motion. So when we have an injury to a ligament, we're not just disrupting the mechanical properties of that knee joint, that ankle joint. we're also going to decrease the proprioception. So we often see re-injury because we've disrupted both the mechanical and the proprioceptive stability of that joint itself. The other thing to keep in mind, as a ligament heals, it usually only gets to about 80% of its original mechanical properties, and it also has a decrease in proprioception. So if you have injured your ankle, like an ankle sprain in the past, you're more likely to get a re-injury even after full healing because those ligaments that you injured are probably not performing 100% of their mechanical properties as they were prior to that injury. In general, tendons and ligaments heal with the same 3 phases as other tissues, but there are a few unique things worth noting. With tendons, healing is probably the longest, so it's quite slow to heal a tendon, and there's a strong tendency towards a residual scar at the end of that healing phase. So you're left with an inferior tendon than prior to injury because the interface between that scar and the normal tendon is a place of high stress. So you're more likely to get injury there, and also the mechanical properties are going to be different. The other thing to note about tendon healing is it requires some stress and some movement to align those collagen and reduce adhesions. So early mobility is going to be important. If the mobility is delayed or there's prolonged immobilization, the outcomes are going to be worse. Ligament, like a tendon, it heals pretty slowly, but not quite as slow as a tendon in general. It's going to start with a disorganized collagen in that proliferation phase. It's going to be slowly remodeled over time in that remodeling phase. However, that final ligament is going to have some residual disorganization. So even after healed, like I said in the previous slide, you're only at about 80% of the mechanical properties of that ligament prior to that injury. So you're more likely to get that re-injury. Another thing to note is extra-articular ligaments tend to heal better than your intra-articular ligaments. In a previous video, we talked about the properties of muscle, but we didn't get to injury and healing. I'll link that video in the description. So let's talk about the grades of muscle strains. A grade 1 is a mild muscle strain, so that is microscopic tearing of a small number of muscle fibers. The important thing here is that the fascia remains intact. Have some local discomfort and tenderness, but swelling and bruising is going to be minimal. If there is pain or discomfort, it's going to be mainly at the end range of stretching or with a strong resisted contraction. Strength is going to be mainly maintained, range of motion is still full, and largely you can function as prior injury. Typical recovery is approximately 1 to 3 weeks, depending on the demands of that sport, or if you re-injure it. Typical recovery lasts about 1 to 3 weeks, and return to sport or activity depends on the demands of that sport. Next, we have our grade 2 or our moderate muscle strains. Now we have a partial tear involving a larger proportion of fibers and the fascia, but it's not a complete rupture itself. So there's going to be acute pain with noticeable tenderness, swelling, and often, especially if it's superficial, you're going to have some visible bruising to that area. Contraction and stretches are clearly painful, so moving it or having it passively stretched, that's going to be painful. Movements are going to be affected, so you're not going to be functioning at 100% with this grade 2 muscle strain. You're going to have a definite loss of muscle strength when you compare to the other side, and you may see some limitations in range of motion. Function is usually going to be impacted, but you can usually compensate for those functional losses in other ways. Typical recovery, several weeks to a few months. That's going to be longer for high demand sports with a lot of ballistic, a lot of plyometric types of demands. Finally, we have our grade 3 or severe muscle strains. This is a complete rupture of the muscle or the musculotendinous unit. It's going to be an onset of sudden severe pain, often accompanied with a pop feeling of that muscle itself. Swelling is going to be marked. You're going to have a palpable ball where that resection of that muscle occurred. So complete loss of muscle function, unable to continue whatever that movement that you were doing prior to that injury. This is often going to require surgical evaluation, especially for athletes or when that muscle is really important or is not redundant with other muscles. Typical recovery is months. The timeline is variable depending on the surgery and the type of rehab that is prescribed by that surgeon itself. So what are some predisposing factors to a muscle strain? Two joint muscles, that's going to be our first one, because it's easier to overly stretch a two joint muscle because you can stretch it across both of its ends. So a lot of strains occur when you have a two joint muscle that is being stretched across its proximal and its distal attachment. So think about a hamstring strain, that's usually going to be our two joint hamstrings. Also, these two joint muscles often have a higher percentage of type 2 muscle fibers. So again, those type 2 muscle fibers contract more forcibly and more rapidly than type 1 fibers. So you're going to have a muscle that is strong and able to contract rapidly. So often this occurs during an eccentric contraction because that muscle is being lengthened across both of its joints as it is forcefully contracting. So again, your hamstring is a good example of a muscle strain because it's going to be lengthened in hip flexion, knee extension. And if I'm slowing that down with an eccentric contraction of those powerful type 2 muscle fibers, I'm more likely to get a strain of those two joint hamstring muscles. So muscle tissue follows the same three phases as any other tissue. You have your inflammation phase, your proliferation phase, where they deposit that scar tissue. So hematoma in the inflammation phase, that's going to be replaced by a scar in that proliferation phase. And in that remodeling phase, we're going to slowly contract that scar down to its final form. So one thing to keep in mind is a muscle will keep its scar forever. So once you've torn those muscle fibers, they're going to heal with a scar, and that scar is going to remain. It's going to shrink down to as small as it can be in that remodeling phase, but it is going to remain. Because of that, you have an interface between your active muscle tissue and that scar. That's a place where there's high stress and you're more likely to get injury to that same site again later. Now let's talk about the impact of a muscle being held on stretch for a prolonged period of time or shortened for a prolonged period of time. If a muscle is under stretch over a long period of time, it's going to add sarcomeres. But it's not going to add those sarcomeres in parallel like when you strength train. When you add sarcomeres in parallel, it makes that muscle stronger. However, when a muscle is under stretch, it adds sarcomeres in series or lengthwise. So that makes that muscle longer. So what's the impact of that? It changes the length-tension relationship of that muscle. So now instead of performing optimally in a normal range of motion, it performs optimally in a longer, towards the end of that range of motion. So think about your scapular retractors. So your middle trapezius, your rhomboids. You're in front of your computer all day, studying, working, whatever. Those muscles are under stretch. They're going to add sarcomeres in series. So now that middle traps, that rhomboids, performs better with your shoulders rounded than when they're in their normal position. Often you might see a decrease in those sarcomeres in parallel. So you're going to see an atrophy in parallel because they're under stretch over a long duration. So they're not being able to perform optimally. So it's going to change that length tension relationship and allow it to perform in positions that are not normal. So it's going to feed further into those postural changes. Firstly, when you have a muscle that's shortened over a long period of time, so it could be bed rest, it could be sitting in a chair, your hip flexors are constantly shortened. So because they're always in a shortened position, that muscle is going to adapt by losing sarcomeres in series. So it's going to make that muscle shorter. So therefore, it's going to be harder to lengthen it now. So it might be stuck in that position of shortening if it's shortened over a prolonged period of time. The final thing I want to talk about today is the ability of tissue to adapt to different amount of stress that are imparted upon it. This physical stress theory is applicable for single tissue, such as a tendon, a ligament, a muscle, or a bone. And the amount of change or the rate of these changes is going to be dependent on that tissue itself, but it's also applicable to the whole body itself when you're starting to add up the stress to all these different tissues. On your vertical axes, you have the amount of physical stress, so the amount of stress that you're putting on that tissue, and you go through some different zones. Let's start with our maintenance zone here in the middle. At this point, you're doing the usual amount of activity. So you're not doing less than usual, you're not doing more than usual. So there's no stimulus for that tissue to increase or hypertrophy or to atrophy. So this is your maintenance zone. If we go up one level to the vertical, we have an increase in the amount of physical stress on that tissue, but it's still an increase that your body can adapt to. So this is our hypertrophy zone. So muscle is going to be adding sarcomeres in parallel. Tendons and ligaments, they're going to be adding collagen fibers along those tension lines. Bone is going to be adding calcium along those tension lines in accordance to Wolff's law. If we go up one further, we're in our injury zone. Now we've increased the stress to that tissue beyond what the body can heal from. So we're in an overtraining type of situation. So in this point, we are breaking down that tissue faster than we can heal from it. And if we keep going, we can lead to death of that tissue itself, or even death to the body itself if we go too far. Going one down from maintenance. Now we're in our decreased tolerance or our atrophy phase, adding less stress to that tissue. So if you were running 3 miles prior to school, now you're running 1 mile twice a week. So now the tissue has less activity or less stress is being imparted upon it. So it doesn't need all that tissue. So it's going to start to break down muscle. So you're going to lose sarcomeres in parallel. You're going to start to lose collagen to that ligaments and tendon. The bone mineralization is going to decrease because it doesn't need that tissue to maintain. And your body is always trying to use the least amount of tissue possible to be functional. And if we keep being inactive, we can lead to death of that tissue itself or to the whole body if it's across multiple different systems. One thing to note here, bed rest tends to really quickly go to that area of death. You lose that tissue very rapidly during bed rest compared to other types of disuse. Thank you for joining me today for our third episode related to physiology of tissue. Today we discussed the properties and healing of tendons, ligaments, cartilage, and bone. Thanks again for watching, and don't forget to like, subscribe, and leave me any question you have in the comments. I'll see you next time.